Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as your program facilitator and will present your questions to our panel of physicians. This evening, experts on hernia repair, gallbladder removal, gynecologic surgery, for ovarian cysts and hysterectomies. We'll answer your questions about all things robotic surgery. We'll learn about this cutting-edge surgical technology, including how it works, the benefits, what procedures can be done robotically, what to expect during recovery, and much more. Well, thank you so much for submitting your questions in advance. The questions that you'll hear me asking the physicians tonight are submitted from you all right when you registered for this webinar. If you have any additional questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you'll see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you are experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Finally, don't worry, we've taken the liberty of muting everyone's line to eliminate any background noise, so feel free to move around and get comfortable. So with that, I would like to introduce our experts for the evening, starting with Dr. John Phu of General Surgery and Dr. Miriam Harden of Gynecology. Well, thank you so much both for joining us tonight. I know we're going to have an engaging conversation, so let's jump right into it with our first question for you, Dr. Phu. We'll get to it. All right, our first question to begin with. Can you talk a little bit about the pros of robotic surgery compared to an open surgery?
Thanks, Sarah. I just want to say good evening to everybody. Thank you for zooming into our webinar. It's a pleasure to be here with Dr. Harden and Sarah to talk about robotic surgery here. Just to give you a little background about myself, I'm a general surgeon at Lansdale Hospital, and I graduated Abington Surgical Residency back in 2017, and up here in Lansdale for general surgery practice. So just to give everybody an idea of what the robotic platform is, Chelsea, if you want to pop up the slides, robotic assisted laparoscopic surgery is referring to the Da Vinci intuitive surgical system. It's an ergonomically designed console where the surgeon sits while they're operating. And Chelsea, are the pictures up? Oh, there we go.
There you go.
And so that's the first picture of the robotic arms. Those are the instruments that would be in the abdominal cavity doing surgery. And there's a, next slide, a patient side cart with robotic arms along with the surgeon console on the left there and the 3D HD vision cart on the far right there. Next slide. So all those come together and they integrate into a system where the surgeon is sitting at that console doing surgery right beside the operating room table, and the assistant is at the bedside helping with instrumentation. Sometimes, usually there's 3, sometimes 4 small incisions made through the abdominal wall, allowing tiny instruments that the surgeon has full control over to work at the console to do their surgeries with a 3D high definition camera. Next slide. As you can see, an example of that instrument, those are some graspers, and they articulate. They're about the size of the pencil eraser on the pencil head. So they are quite small, and they do some very fine dissections for gynecologic and general surgery as well. The surgeon has full control of these instruments at all times. Nothing is operated without their instruction. Next slide. So you can see this is just to show that the instruments are very articulated. They have more degrees of freedom than traditional laparoscopic instruments, and more articulation than the human hand. And it's like as if we were able to shrink our hands and place them in the patient's abdominal wall to do small dissections and do big surgeries with these small cuts. Next slide. This is just an example. It's a sort of a virtual console, but those would be the instruments that would be used to sew and cut and do fine dissection. And that's controlled at the surgeon console, demonstrated by the picture below, that whatever the surgeon is using to instruct the robotic instruments to perform, they will translate directly to the robotic instruments to perform that task or procedure. I think that's it for the pictures. So just to address the pros of robotic surgery, I found that my postoperative patients have needed less pain medications, less narcotics needed, because it's a finer dissection, it's more directed, and they avoid a lot of nerves that may be encountered during open surgery. Smaller incisions lead to smaller risk of surgical site infections. With the robotic system, there is a more clearly magnified operative view with the 3D vision camera. It also gives a surgeon, especially depth perception, that traditional laparoscopy doesn't. It's very good, but it only gives you 2D vision. I mentioned before, fully articulated instruments that is very precise and controlled by the surgeon at all times. And has better dexterity and eliminates any natural tremors that the surgeon may have. And the robotic instruments will sort of smooth those out.
Okay. Well, thank you first for taking us through those pictures. I think already just seeing those visuals probably helped a lot of people watching tonight. So appreciate that. As a quick follow-up though, do you mind talking through any cons of the surgery? Any cases you can think of where you might suggest an open surgery instead of robotics?
Sure. Of course, it can't be used for everything and anything. But some of the cons, maybe I mentioned about cost of the instruments, but as it's becoming more widely adopted, the arguments for higher costs are coming down. The Da Vinci surgical system is covered by most insurance plans under minimally invasive surgery. I would say in general, maybe very large hernias could be prohibitive or difficult with robotic surgery instruments. Not saying it's impossible, but could be more difficult. And so traditional open procedures may be more appropriate in that situation. For robotic surgery, the patient should be able to tolerate general anesthesia, so be intubated and completely relaxed. Some patients may not have good cardiopulmonary function, and so therefore they may not be candidates or appropriate for general anesthesia and therefore not robotic surgery. And this is a relative contraindication sometimes when people are on some blood thinners or novel anticoagulants. The bleeding risk could be a bit higher. So not saying it's not possible, but typically, the risk of bleeding with people on blood thinners may be a little higher for robotic surgery, and so therefore open may be more appropriate.
Okay, well, thank you so much. We appreciate it. All right, Dr. Harden, let's turn to you for the evening. A question for you, and feel free to go and introduce yourself as well, but I'll state the question now from the audience. We received quite a few questions about hysterectomies being done robotically. Could you just give an overview about how exactly this is done? Oh, I think you might be on mute.
All right, can you hear me now?
Perfect.
Okay. Perfect. Good evening, everyone. And I also echo Dr. Phu. Thank you for joining us to learn about this wonderful innovation. And I have been practicing since 1996. I finished my residency in OBGYN and started right away at Chestnut Hill for a while. I perfected just traditional laparoscopic surgery. Obviously, residency is wonderful training, but when you get out into the real world, you really, are independent. And I felt I was able to really grow with traditional laparoscopic surgery over 5-6 years of practicing, and actually moved into single port procedures. And I was so excited about that because single port procedures allow for no scars on the patient's abdomen. And I was extremely excited about offering hysterectomies without any visual distortion of the body. I eventually came over to Abington, well, actually to Mercy Suburban. And that's where the robotic training was introduced to me. And this was in 2010. So I was able to train, and I fell absolutely in love with the robotic system for all of the reasons that Dr. Phu has presented to you. And I really feel like, as far as robotics go, it is the best innovation that I've seen in laparoscopic surgery by far. And I don't think it's going anywhere. I think we've sort of reached that place in life where you really have perfected laparoscopic surgery. So let's dive into hysterectomies. What is it? It's simply the removal of the uterus. And when you look at stats for hysterectomies, we're looking at about 600,000 cases a year for women. So it's about a third of women annually that will be confronted with this particular case. And you can do it different ways. You can do it through the vagina if it's appropriate. And that's actually one of the safer ways. You can open, obviously, and that comes into play for a really large disease. We have something called fibroids, which I'm sure women are quite aware of. And those fibroids can grow to the size of a full-term baby. And so obviously that is a little prohibited size for some of the laparoscopic cases. So that's where open cases come in. And then you can also do it through laparoscopic surgery, whether it's traditional or you're moving into the best, which is minimally invasive robotic surgery. Hysterectomies can involve removal of the uterus alone. You can decide to leave your cervix in place, and that has become popular with people that have a healthy sexual appetite, and they don't want any changes in the vaginal vault. So what their partner experiences does not change because there's no disruption of the cervix. You might want to maintain your ovarian function and just remove the uterus and leave the ovaries behind. And that allows your hormonal function to continue until menopause.
Okay, thank you so much. And you touched on this a little bit. Any other pros and cons to this approach you'd like to highlight?
Oh God, yeah. I mean, it's funny. Dr. Phu and I have not shared any dialect, but for me, one of the biggest changes for me was blood loss. And when you're dealing with these large tumors, you get a little bit of oozing throughout these open cases, and you can end up with anywhere from 200 cc's, even up to half a liter of blood loss, because the tumors have a lot of accessory vascular penetration, and they just ooze while you're operating. With the robot, I literally am always asking, what is my blood loss? And they go, minimum. Like, what does that mean? It means we can't measure it. And so we guess around 20, 25 cc's of blood loss. And that, for me, was a major breakthrough for fibroid treatments of fibroids. So blood loss for me has been a really nice benefit. Why do we care about blood loss? Because oxygen is necessary for wound healing. So if you can control the blood loss, you get a better outcome with your incisional healing. Hospital stay is another one, and I'm sure John has noticed that. We normally keep people 2, maybe 3 days when they're open cases, because when you open someone, it might be a vertical scar or a transverse scar, which is kind of a bikini cut. And so it takes a couple of days before you can ambulate and take care of yourself. The first few cases with robotic surgery, I was quite surprised at how patients were waiting on me, irritated by 10 o'clock in the morning because they wanted to go home. So hospital stay on an average is 6 to 12 hours for hysterectomies. And when you do an open case, you're talking about 2 to 3 days for hospital stay. Another really, really good thing is I think he hit on this decreased infection rates, because obviously when you have an open wound, there's more exposure for the tissue to the air. So less infection, smaller incisions, quicker healing. There overall is less complications because it's a more precise surgery, as Dr. Phu described to you. with the 3D HD capability and these fine endo-wrist instruments, you 100% do a better dissection. Another, and I'll stop with this, is I always struggled with standing over the traditional way to operate laparoscopically. You have to stand. So now I'm sitting in a chair like I'm talking to you, and I'm 100% comfortable, and I can operate in ease. I can, with patients whose BMIs might be over 30, 35, 40, somewhere in there, it got quite difficult to reach certain deep areas in the pelvis with the traditional instruments. And with the Da Vinci, it allows you to take whatever surgical site you're operating on and literally bring it this close to you, or move it all the way back. So that 3D depth is just something you can't beat. So those would be some of the really good highlights. And the cons, I think really just the time, and I've perfected my time because I've been doing it since 2010. You get better at it, like anything, but it is a longer procedure because of the setup. On average, a setup might be 30 to 40 minutes. And when you make an incision, you're talking about 15 to 20 minutes to get into the surgical site. When you have a team of people that work together every day, they get fast. They get faster, they get more confident, the surgery goes quicker. So what started to be 3 to 4 hours for me for a robotic case is now down to 2 to 3. So it does improve, but the time difference means more anesthesia, and that can mean more swelling because you are in a deep Trendelenburg position during that time.
Well, thank you so much. Certainly a lot of pros, obviously a few cons. So thank you for talking us through that, but many factors for people to consider when looking at this. So thank you. All right, Dr. Phu, we'll turn to you. And, we kind of saw this a little bit in the pictures that you showed earlier, but how does new robotic technology change the role of the physician during the surgery?
Yeah, thank you. So I think the role doesn't change. The surgeon themselves still is your doctor, still your surgeon. You're still doing your surgery. The robot's not on autopilot. Nothing is done without their control. It's just an advanced surgical tool that we are able to utilize for general surgery, repair hernias, take gallbladders out, and do gynecologic surgery. So our role doesn't change. It's just that the tool is much more advanced. Just to echo Dr. Harden's point there, also our role as surgeons at the bedside is still there, but our ergonomics are so much more better. With open or laparoscopic surgery, we contort ourselves and bend and twist in different ways to kind of get the better angle or suture the right thing. What Dr. Harden mentioned is that you're at the console and you're in a comfortable position without needing to contort and twist your body to do what you need to do. The robot does all the work and helps the surgeon greatly in terms of their ergonomics. But like I kind of mentioned, each of the robotic arms and instruments are under my full control at all times. So like I said, the suturing and cutting is translated precisely from my hands to the body. And so nothing goes awry without us knowing about it.
All right. Exciting to hear. All right, Dr. Harden, back to you. Let's talk about reliability for a second here. How reliable is the surgery, and what kind of pain points do you see when you switch from a robotic procedure to an open procedure?
Sure. Reliability is really, kind of reflected in some of the things we've discussed, because traditional laparoscopy, it's wonderful, but it's quite difficult because the dissection that you're doing in some cases can be quite complex, and you're standing over the body and you just don't have the flexibility with your hands. And the instruments are not designed like the robotic instruments. So I'm going to show the audience, this is actually an endo-wrist instrument. And you see how I can move it this way, that way, up, down, and it can torque around. So I can't do that with an instrument that is a traditional instrument. So that alone allows a precise dissection. And we can't stress enough the visualization, because if you can't see it, you are going to miss something. So sitting in a microscope, you're looking through a microscope, right? So everything's magnified to me when I'm sitting at the console. And like I said, I can bring things very close. So I think precision makes this very reliable to do the proper dissections. It allows you to visualize. We as gynecologists are obsessed with the ureter because we always get blamed for injuring it. So we always dissect it out or aware where it is at all times. So in robotic surgery, you can see it so beautifully peristalsing against the side wall because of the magnification. And it allows you to do very complicated surgeries for endometriosis cases that I was just not able to perform because I have this 3D high definition approach now, and I have instruments that can do a range of motion that my hands just cannot perform. But because of the endo wrist being so flexible, I can perform a lot better dissection. So it is very reliable. As far as pain, it's really one of the biggest reasons to have it. Think about making a large incision, maybe, I don't know, 5, 6, 7 centimeters, depending on the disease that you're trying to remove. That has to heal. So you're making this incision, you're dissecting down through all of the components that make up our skin layers, our fat layer, and then down into the muscle. And we end up cutting the muscle often. That leads to swelling and bruising, and such a difficult way to wake up and have to feel the intense pressure from all of that I'm describing. And then even beyond that, all the action, when you have these instruments inside, is inside the body. I'm not pushing on the skin. I'm not pulling on the skin. It's all happening internal. And so the patient is not feeling any of that. So the pain is really one of the main reasons to do robotic surgery, because your pain is so much less. I'd say on average, we're looking at 1 to 2 weeks for patients to return to some form of activity, whether it's working from home, or something like that. Whereas if I'm doing an open hysterectomy, we're talking about 6 weeks before they're going back to work. So it's a big difference, huge.
Very big difference. And I think both of those points, reliability, and recovery even, which I know we'll get into with our next question, but that is both very reassuring, I'm sure, for people listening. So thank you. Okay, before we dive into our next question, talking all about recovery, just a quick reminder, if you have any questions, stemming from our discussion, feel free to drop them in the chat, and we'll make sure that they get answered. Okay, Dr. Phu, turning to you, let's dive into recovery, because I'm sure that's a big topic people are itching to hear. So can you just talk a little bit more about what patients may expect when it comes to recovery time?
Sure. So we'll address it in the frame of hernia surgery. Typically, these are same-day procedures. I do them at Lansdale Hospital. They come in, they have it done, and should go home the same day for the most part. Recovery afterwards, I instruct my patients just to be on light duties, nothing more than 10 to 15 pounds, for about 2 weeks when I do a robotic laparoscopic approach. When I do an open surgery, I kind of push that out to 4 weeks. So there is a slight quicker recovery. And I do see them in the office post-op at 2 weeks for a check in general. But recovery times, like I said, with smaller instruments, smaller incisions, they should be able to get back on their feet more quickly. Dr. Harden had expressed that with the camera, the high definition and the finer dissection, the surgeon appreciates much more detailed layers during the dissection. So they are able to avoid injuring any nerves or any other important structures. And so that does translate to better outcomes and recovery times for the patients after the surgery itself.
Okay, great. Thank you. And Dr. Harden, do you mind just discussing a little bit more about recovery times for hysterectomies and other gynecologic surgeries?
Sure. So let's just talk about open cases because that might be more familiar to some of your listeners. So when we do hysterectomies, myomectomies, or removal of pathology, like a ovarian tumor or something like that, some of it is outpatient, like Dr. Phu's cases. So if you have a dermoid cyst, which is a cyst that can grow in the ovary, that's benign. Basically, I can remove that cyst. It's called an ovarian cystectomy, and that's a same-day procedure. Those patients classically recover within a week. Most of them can go back anywhere from 7 to 10 days. If you were to open someone for a case like that, they would be looking at least 3 to 4 weeks. Hysterectomy, open cases, like I said, 6 weeks for sure. And that's just because of when we think about recovery time, it's not just the surgery, it's a lot of swelling that develops when you're, going through all these tissue planes. And then we use retractors. These retractors push on the side wall of the pelvis, and they push on the skin, and that leads to swelling. So most people after surgery, after an open case, they're complaining about, why do I feel pregnant? Why am I so bloated? Why do I feel so large? Why is this swollen? It's because of all the tissue damage that's occurring. So what the Da Vinci allows you to do is not have any of those problems, because once those instruments are locked into place on the robot, like that diagram he showed you earlier, it's fixed. It's a pivotal point, and there's no pressure on the skin. So you're not getting the damage to the subcutaneous tissue and to the deeper layers. So we're looking at, in fact, my biggest problem with robotic surgery, with hysterectomies, is convincing them not to start swimming and lifting their kids and running around and going out of town. I'm like, no, you still had surgery. So I feel like the time for hysterectomy as far as recovery is half the time for most patients, and for some patients that are really, really just aggressive, maybe a third of the time. So it's recovery time is a big bonus for robotic surgery.
Thank you. A lot of pros, certainly. Okay. Now, as we're talking about, this advanced technology, I think a question many people have is insurance and whether, insurance covers this type of surgery. Dr. Phu, can you comment on that at all? If, are these surgeries covered by insurance?
Sure, absolutely. Short answer is yes. The surgery with the robotic surgical system is classified under a type of minimally invasive surgery. So that does include robotic surgery and traditional laparoscopic surgery as well. Most insurance plans do include robotic surgery in their minimally invasive coverage, but obviously everybody's plan is different, and you just check with your carrier. But for the most part, they do cover that.
Okay, great. Thank you. All right. I know we talked a little bit about anesthesia earlier. So Dr. Harden, can you describe the anesthesia process for these procedures, and would more or less be used for robotic surgery?
So the medications that are administered for induction and keeping patients asleep are pretty much the same. The biggest difference with the anesthesia is the time. So when you're learning about robotic surgery, in my field, you're looking at about 3 to 4 hours of anesthesia. When you do an open case, you're looking at most likely 2.5 hours of anesthesia. So there is a difference. Now that time definitely improves with the amount of cases you do, because you get faster and your team gets better working around you and anticipating what your needs are. Why does it, I think a nice way to address this question is, why does it take so long? Because you have to set up. You saw all of those components that Dr. Phu showed you. The part that the patient cart, that has to be set up for the patient. So that means placing the instruments inside the abdominal cavity and locking them onto the robot. Or for for gynecologic surgery, what it means is something different. We have to put something that's called an intrauterine manipulator into the uterus, and that's done vaginally. Takes about 5 minutes or so to pop in. And what is that? Why do we have to have that instrument? It allows me to rotate the uterus side to side, up and down, or at any angle I want. Because when you're operating, you have to have a mobile uterus in order to move it out of the way, because these are usually pathologic tumors that are big and in the way. So as you manipulate the uterus and move it, away from the surgical field, you have to have this manipulator. It also gives you a nice ring around the cervix, and that ring allows me to cut around it. And that is where the vagina is below that. So that releases the uterus and you pull the specimen out through the vagina. So it's a really amazing device, but it takes about 5 minutes or so to place. The patient cart might be about 10 to 15 minutes, and then arranging other parts of the surgical team takes a few minutes. So all in all, about 35 minutes to get just set up. So that's really where the difference in anesthesia comes in.
Okay, thank you so much for taking us through that. We appreciate it. All right, Dr. Phu, we'll turn to you and talk a little bit about hernia surgery now. How long is the surgery and what does recovery time look like?
Sure. Chelsea will put up those last two pictures. So I'll kind of talk about it from start to finish. So this is a picture of inguinal hernia. One more slide. Yeah. So one behind that, before that. There we go. Thanks. So I use 3 robotic arms. One of them is for the camera, and then the other 2 is for my right and my left hands. The instrument on the left is typically called a fenestrated bipolar that helps me grasp and retract tissue and organs. And the instrument on my right side, on my right hand, usually is a cautery scissor, and that helps cut and kind of dissect the planes. I will put the camera port somewhere around the umbilicus, around the belly button. And then I put the other 2 trocars about 10 centimeters away from that middle one at the belly button. At that time, the robotic Da Vinci cart arms I had showed pictures earlier will get docked onto those trocars, and then I go to the console. At that time, we put the instruments I mentioned in, and then we look at the hernia. At the picture here, it's got some indications about an inguinal hernia. That's where the ring is, where there's a defect where hernia contents can come out of. Some of the vessels and the testicular anatomy is shown there as well, and that's what we try to pay attention to and avoid. But the first step is, after anesthesia and docking all those instruments, takes about 20-25 minutes. We start making a plane or a little flap that takes down the lining of the abdominal wall off of the muscles. And that helps us take down the hernia sac and all the contents of the hernia and fully reduces it. That takes about 90 minutes or so, depending on the difficulty or the size of the hernia. And once that's fully reduced, next slide, you'll have something that looks like that. There's an open pocket. This obviously here has a piece of mesh already, but that sort of pocket is where the hernia has been reduced. The anatomy has been identified. If we go deeper, you'll notice the pubic bone is in that area too as well. Once we have our view that we're satisfied with the hernia is fully reduced, then we'll put a large piece of mesh sized appropriately to the patient's anatomy and place it across what we call the myopectineal orifice to cover all the hernia orifices. At that time, I'll put a couple sutures at the bone or at the muscles, avoiding the nerves that kind of anchor the mesh in place. After that, then I will just sew that lining back up to cover the mesh so it's not exposed to any intra-abdominal organs. And so that mesh is permanent. It stays there because it reinforces the wall and the repair, and the lining of the abdomen is closed, so there's nothing exposed. After that, the instruments come out, the trocar is removed, the gas is sucked out, and surgery is done, and they're extubated. Let's see. How is the recovery? I had mentioned before, typically 2 weeks recovery. No heavy lifting more than 10 to 15 pounds, but they are encouraged to ambulate. Tylenol and Advil for pain control. In terms of getting back to work, typically if it's a desk job or nothing too strenuous, a few days after surgery, they're okay to do that. If anything in terms of manual labor or heavy lifting, I encourage to wait at least 2 weeks until I see them in the office before engaging any strenuous activities or exercise.
Thank you so much. Seeing those visuals again, I think just really helps paint a nice picture. So we appreciate you walking us through that. And as we're looking at this and just seeing these, again, technological advances, I think a lot of our audience members are curious if there's any new trends or upticks in robotic surgery. So Dr. Phu, if you don't mind just speaking a little bit about that.
Sure. So the Da Vinci platform is a tool, and is used across all different specialties. Obviously, general surgery, gynecology. You will see this in urology as well, and thoracic surgery, also ENT. So the breadth of its abilities is very large. But I will comment on some of the newer trends for general surgery, at least. We are seeing hernia repairs done, what they call ETEP, extended extraperitoneal access. It's a way to do hernia repairs without getting into the abdominal cavity. We kind of just sneak right below the muscle layers without getting into the abdominal cavity, and able to fix hernias that way without getting into the abdomen. So that's kind of an up and coming new technique. Other things that is possible with hernia repairs is component separations. Those are more geared towards larger hernias that are bigger than what we're used to for traditional repairs. This involves cutting certain muscles to give a release to offload the tension on the abdominal wall so that things can be sutured back up in a large piece of mesh to cover a large hernia defect. So component separations and extraperitoneal approaches are some newer ways of approaching abdominal hernias. Also, you're starting to see this being applied to certain trauma settings too as well. I've seen some other surgeons across the country who applying robotic surgery in a judicious way for certain trauma patients too as well. So its use is expanding in an appropriate way.
Okay, and Dr. Harden, anything you'd like to add that you're seeing?
I think what I've seen since I started is GYN oncology. They almost exclusively are doing these major dissections and metastatic cases robotically now. And that offers these patients a much quicker recovery in their post-operative course, and they can get to their chemotherapy sooner. And so in that area, I think we're seeing a lot of innovation going on in GYN oncology. Just as far as the robotic system, I mean, they've been improving upon it. And there's different generations. We're up to 4th generation systems now. And I was, it's kind of like having a cell phone now, and the first computer was bigger than this whole room. So same thing is happening with the actual robot itself. It's smaller, sleeker, it's automated. The table, there's like integrated table motion. And as far as the OR team, they have a lot more flexibility with setup because it's automated, and it promotes a lot of OR efficiency because it's less for them to do. In fact, the biggest thing, and I think this is really going to lead to safety that they'll really be able to measure. The latest robot targets an organ, and as you insert a camera, it will not seed until you are targeting where you're operating. So for me, it's the pelvis. For him, it might be the upper abdomen. So it rotates until it targets it perfectly for position. And that's a big deal because that helps with the ease of surgery.
Absolutely. Very cool to hear. Thank you. All right. Well, thank you for everyone listening and watching, because I know we've been receiving some questions in the chat, which we're excited to dive into. Just one last question before we dive into our live audience questions for both of you. If you don't mind just speaking about who would be considered a good candidate for robotic surgery. And whoever wants to start first, feel free.
I'll let Dr. Harden go first.
You've been volunteered.
All right, so, some of the indications for robotic surgery overlap, but of course, I mentioned cancer of the uterus because that's something that in the past you really were not a candidate for a lot of the traditional laparoscopic stuff. So cancer is a big one. Prolapse uterus obviously is a great one. Fibroid tumors, that's probably our bread and butter because it's, 1 in 2 women have fibroids. Abnormal uterine bleeding, endometriosis. And as you see, I'm talking obviously all of these disease, gynecologic processes can happen with open cases too. So some of the indications overlap. Something that I think we do much better is endometriosis, because endometriosis is similar to metastatic cancer and how it behaves, because you get so many really dense adhesions. You get a lot of organs that are just plastered to each other and stuck to each other. It can really sort of not only involve the lower pelvis, it can be the upper pelvis, it can extend into the abdomen. So the robot allows you to move around and really visualize the lesions. Doing it traditionally, I would miss half the lesions because my depth perception and my vision was just not able to pick it up. So I think we've made huge advances in resecting endometrial implants. So I think my favorite thing about the robot is that, and plus working on, I hate using the word obese. I'm going to use BMIs that might be a little bit higher. I feel like it has just revolutionized. It's so much easier. And I think it's so much safer, not only for my surgical technique, but also for post-operative care, because a lot of patients with larger BMIs have diabetes. And when you're making these large incisions, a lot of them open up. It leads to wound infection, wound separations. And with these nice, tiny, precise incisions that aren't buried underneath a big pannus, the complication rate is definitely a lot better. And also, because they want to walk around right away, that leads to less pneumonia, less blood clots, and less complications.
Okay, thank you. And Dr. Phu, any candidates that are good for your robotic surgery?
Yeah, in the lens of hernias, people that may have bilateral or left and right inguinal hernias are good candidates for robotic surgery. The reason is I would still use 3 small incisions, but the benefits is I could see the left and the right side and repair both at the same time with the same cuts. I don't have to make 2 separate open cuts just to fix the right and left side. So that's a benefit there. Also for recurrences of hernias that may have been performed or done from an open approach, the plane from the posterior side is much more amenable for dissection because it hasn't been taken down. And so anybody that may have had an open hernia repair and has come back, a robotic repair would be appropriate for those type of patients because you're addressing it from a different plane. It's like shingling the roof from the inside, so to speak, if you have a recurrence. People with abdominal wall hernias that may be Swiss cheese-like, so they don't have just one hole, or one big hole. They may have several small ones all clustered together, like a Swiss cheese type of hernia. And those can be tricky to fix open because you're just going to need to make one big incision and sort of assemble all the holes together and make one big repair. Whereas for the robotic approach, you can use, again, 3 small incisions and close up all of those several holes together and put one large piece of mesh to repair all that hernia through, again, 3 small incisions rather than one big cut. So those would be ideal or good candidates for robotic surgery hernia repair.
Okay, well, thank you. I think with that, let's head into a few live questions that we're getting from the audience. So to kick us off, Dr. Phu, I'm going to turn to you. Great question here. I'm very curious to know, what is the role of each robotic arm?
Sure, yeah. So in that picture, it shows you 4 arms. And one of them is the camera. So you've got to have a camera for sure. The other 3 depends on what you want to use them for. For me, 2 of them will be for my right and left hand to simulate what I do in open surgery, so to speak. One will be for like a bipolar or something to grasp tissue, maybe cauterize some things, stop some bleeding and blood vessels. The other arm, I would use scissors, and that helps cut and dissect and take down structures. And those are my typical instruments. So the left and right arm with scissors or graspers, and then the camera. So that's 3. Sometimes we'll use 4 for a gallbladder, in which case, 1 arm is for the camera, of course. 1 is for dissecting the gallbladder at the cystic duct. And then the other 2 arms helps lift up the gallbladder over the liver to help dissect the cystic triangle there. So depending on the surgery, it's 3 to 4 arms, and each of those tools, depending on what you want it to do, you can either cauterize or cut or grasp tissue, depending on your purpose. I'm sure Dr. Harden has her specific tools too that she likes to use.
Yeah, some of them overlap. Certainly the camera, obviously. We both are using a similar camera. And then I always use bipolar energy and scissors that are capable of monopolar energy. So I, usually will have the scissors in my right hand, and I'll have the bipolar in my left. Because the bipolar energy, I love it. It's a grasper, so I can grasp the tissue and I can dissect with the scissors. But if I need to cauterize a vessel, it turns into a cautery instrument. I always use 4 arms, not unless it's a simple like ovarian cystectomy. And the reason is for countertraction. You do have assistants in the room with you while you're operating. I don't know if we mentioned that, but there's always an assistant right next to the body at the patient cart, and they can hand you and switch instruments out while you're at the surgical console. It makes sense, right? So that assistant has a port, and that's very important because they can give you countertraction when you're trying to dissect things. Because when you dissect tissue, if it's just laying there, it's not going to give you a nice dissection. You always have to have countertraction. So what I use my 4th arm for is to elevate tissue. And sometimes if there's a lot going on, it's just nice to be able to operate by yourself if there are other things happening. So the 4th arm just gives me the flexibility to do a lot of things independently. And so I train that way, and I will leave it off if it's a simple case, just because it's another small incision for the patient. But yeah, those are the instruments that I use, a grasper. And then obviously when I'm stitching up the vaginal cuff at the end of a hysterectomy, I will have a needle holder in my right hand, and I will use a grasper in my left hand. And that's the way I'll hold the vaginal cuff with the left hand and suture it with the right. Those are pretty much the typical instruments that I use for hysterectomy.
Okay. Really interesting to hear the different uses. So thanks for both taking us through that. Okay, Dr. Harden, we have a more specific question from the audience. This person wrote in, for someone who has severe adenomyosis and has been considering a hysterectomy, can you talk a little bit about what complications would cause you to go from laparoscopic surgery to open surgery?
Yeah, so the specific reasons for someone to abandon a laparoscopic case can be a complication. So if you, it's never happened with minimally invasive surgery for me personally, because I feel like there's just so much room to do a better job. But in traditional, if you got into some type of bleeding, for me specifically, if there is a case of an ectopic perhaps, and there was just blood shooting out during the laparoscopic portion that you couldn't visualize quick enough, you might abandon that because you can lose quite a bit of blood quick. So that's one reason to open. Sometimes metastatic cancer, which I don't do those cases, but I certainly have been a part enough assisting in them. And those cases can be tricky sometimes when you're getting into any kind of laparoscopic surgery, not specific for minimally invasive because it's the best, but you might have to open for those reasons. Let's see, it might be that there's just so much scarring that you can't put your instruments in without damaging other tissue. So those would be the main things, but specifically for adeno, for people that don't know what adenomyosis is, people have really described it recently as in the spectrum of endometriosis. Endometriosis is simply ectopic endometrial tissue in places it shouldn't be, and it can spread anywhere it wants. Adeno is different because it is actually the endometrial lining penetrating into the muscle. So you have all these tiny endometrial implants that are infiltrating the uterus, and it leads to a boggy, bloody, painful uterus that bleeds and causes great pain and discomfort for the patient. So I really can sympathize with this patient. A robotic approach is simply the best approach for you. There's nothing about adenomyosis that would make it more difficult or more dangerous. Your uterus will bleed less as part of a robotic case than an open case because of the dissection we can do.
Okay, thank you so much. Very helpful there. All right, Dr. Phu, question for you. Are types of surgeries like repair of spine injuries and herniated disc repaired robotically?
Oh, good question. I don't know if I'm the right person to answer that. I am aware that there are robotic platforms for orthopedic and spine surgery. They are not the Da Vinci intuitive surgical system we're talking about tonight, but I do believe there are robotic systems for orthopedic surgery and spine surgery in terms of addressing those specific pathologies of the spine. I can't comment, but I'm sure my orthopedic colleagues would be better addressing that. But there are technologies like that out there. Yes.
Okay, thank you. All right, question for both of you. So whoever wants to hop in here, is scar tissue that occurs after robotic surgery less than what would occur during an open surgery? So whoever wants to jump in, feel free.
I would say so. With an open incision, you're making a larger cut, and so you're cutting through more of the abdominal wall layers. In that sense, there's more dissection that's needed and more manipulation of your intestines or organs down in the pelvis or in the abdomen in general. And so that engenders more scar tissue because as your body's healing, it just ends up building up more collagen and scar tissue as it heals. So with robotic surgery, you're making small cuts. You're avoiding unnecessary movements or unnecessary manipulation of other structures or tissues. You're really focused on the one area of your surgery to take care of that problem without dealing with any other adjacent structures. And so for those reasons, I think there's less chance or less risk of developing postoperative scar tissue. There will be some, but I would believe it's less so than a large open cut.
Okay. All right. And the last question for the evening before we close out tonight, Dr. Phu, can you talk a little bit about the sutures for the incisions?
Oh, yeah, it's great. So one of the things Dr. Harden mentioned is a needle driver, and I use that too as well because we do a lot of sewing. And we haven't really said so much about it, but one of the great benefits with robotic surgery is sewing. through these small instruments. With laparoscopic surgery, it's good, but it's not great. Trying to sew with laparoscopic instruments can be a little cumbersome or awkward. And so if you can imagine those wristed instruments with sutures to close the hernia holes or to close the defects of the abdominal wall or to suture your mesh in place, it makes it much more easier and amenable to suture because it just mimics your natural movements of your hands. The sutures I use for the most part are dissolvable. It depends on the type I'm using. If I'm anchoring mesh, I'll use a Vicryl suture that dissolves usually in 60 days. If I'm closing the abdominal wall for a ventral hernia, I'll use a thicker type of suture, PDS, and that takes usually 5 to 6 months, but we need that strength to close the abdominal wall for those hernias, and so it takes a little longer, but at that time, the mesh and your tissue should scar in. To close the lining or the peritoneum, I would use something called a Stratafix. It has like little barbs in there. It helps kind of close the lining of the abdominal wall without needing to do too much knot tying, so to speak. It helps close things a little more efficiently.
Well, thank you. And thank you everyone for these live questions. As I said at the start, I knew we were going to have an engaging discussion. So thank you both. I do have one final question of my own. And just curious to hear, what are your goals for everyone listening in on this webinar? And what would you like our viewers to take away from tonight? Dr. Harden, let's go ahead and start with you.
Sure. So I think my biggest goal tonight is that I wanted to introduce our viewers to this minimally invasive technique and really just stress how innovative it is and how safe it is and how it really has opened up laparoscopic surgery in a way that our women can get back to their busy lifestyles in a much quicker fashion, with less pain, with less complications, because women are busy. And I already told you, a third of women will be faced with, major surgery. So why not, these women lead robust lifestyles. So this is the type of minimally invasive surgery that can allow you to have the surgery that you're going to need, but get back to your robust life and your lifestyle without any trouble or missing too much work. And really just socially, women, laying around in bed with a big, huge open cut, those days are just over. There's just no room and no reason to expose yourself to that type of pain, not unless, you have a 30-week uterus. It's not going to come out through these tiny little incisions. But I think the main thing is just to stress how innovative it is and how safe it is and how really we're moving into surgical techniques for gynecologic care that can get you back up on your feet and get you back to your routine.
Absolutely. I'm sure a lot of people were excited to hear all about the recovery time and everything we discussed tonight. So thank you. And Dr. Phu, any goals you would like to share?
Yeah, I'd like patients and people on the webinar today to just understand that robotic surgery is a significantly advanced form of minimally invasive surgery. It's like the next generation of laparoscopy, and it allows the surgeons to take better care of their patients with better precision, better dissection, less downtime for our patients, and less chance for surgical site infections. And so for overall, this is turning out to be a great benefit for our patients and better recovery times.
Absolutely. Well, thank you both again, Dr. Phu and Dr. Harden, for your time this evening. As we said, a lot of great information was shared, and thank you all so much for submitting your questions and attending this evening. We will be posting an event survey, so you can let us know your thoughts. Was this helpful? Is there another time that might work better for you? Any other specialties you would like to hear from? Your feedback will bring more virtual events like this to you, the patients. Also, if you would like to be contacted to make an appointment with a Jefferson Health provider, please fill out the last question in the survey. If you would like to be Be sure to visit jeffersonhealth.org to make an appointment and stay up to date on events and webinars just like this one. We have another webinar coming up next week, so we'll share that information for you in just a moment. Please also visit thehealthnexus.org for more health content, patient stories, research, innovation, and much more. You can also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to planning for pregnancy to, obviously, robotic surgery. A recording of this event will be sent to you next week, so you can rewatch at your convenience. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining us, and please be sure to stay safe and healthy. Thank you so much and have a great evening.